So this is a gentleman who's 52 years of age, otherwise good health, who had a seizure back in August of last year and presented at a community hospital. A CT without contrast of the brain was this scan, which was read as normal, and really is, I don't show one cut here, but there were no findings on that scan. He was discharged home to be followed by with a neurologist, but never kept that appointment. If we had maybe a contrast scan here or an MRI, might have seen something, but not the scan. Subsequently, he returned, I think 3 months later, with headaches and came into the university emergency room, and at that time had a 7-centimeter mass. And I think I had an MRI. Next slide. Which shows this 7-centimeter peripherally enhancing mass, which is sort of typical of glioblastoma type appearance, peripheral enhancement, central necrosis. So most likely diagnosis is high-grade glioma. He was hospitalized there and had some other scans done to rule out a systemic source of a possible metastatic lesion, which there was none. Options. Maybe we have some audience participation. Among these, I'm not sure how much participation we're going to get, as far as participation goes, but raise of hands for a biopsy.
Looks like it was easy to get.
Pardon?
Looked like it was big enough and easy to get.
We're going to wait on our neurosurgical consult.
Or resection, raise hands for that one. And metastatic workup, I already gave that one away, so we did that one already. Or radiation therapy, chemotherapy, hospice. And what we chose was with Dr. Martino surgery.
I think irregularly, and if we go back to the slide, I mean, it's irregularly ring enhancing, so it's not smooth wall. You know, the things that we consider are metastatic disease, abscesses, and primary gliomas. This is more typical of a glioma because it's not smooth wall. It's a little thicker. It's irregularly enhancing, so it's more consistent, most consistent with that. It's in a relatively, it's anterior, so it's in the frontal lobe, so it's a relatively non-eloquent area of cortex. So it's something that can be resected. So would go ahead with a frontal craniotomy and attempted complete resection.
It's an impressive difference from the CAT scan to this over just a 3-month interval of time. And again, how old was this guy?
52.
So I guess you know, if it's a new onset seizure in a 50-year-old, you've got to be suspicious that there's something more going on. It'd be pretty uncommon for an adult to come in, new onset seizure, and it not be something structural in their brain.
Right.
But I agree, that CT,
Go back to the
it looks about as, I mean, even in the slide, I mean,
I don't think it's fat right there.
well, I think retrospectively now,
Some of
that
the other cuts, you might think you can see something here, and get the same cut as the largest.
Yeah. I think if I was in the ED and saw that, I would have, probably not. I think, an appointment was made, and that was, the appropriate ED management of this. So.
Yeah, and when you have a first-time seizure in somebody like this, you need to think from a neurologic perspective. You think stroke.
Right.
Right. It's 50-ish, right? Is that what you said? Yeah. So you think stroke, and then you think tumor, and then either metastatic or that. So there's further workup that needs to be done here, and it was recommended, but unfortunately did not.
But I think sometimes they don't put the emphasis on this is really important to go and do that workup and stuff like that, and you have to do a lot of education, and through an EU, they're just running people through.
Right.
Usually they've got broken bones and blood, so
Same with us, and also, more than likely, he got put on an anticonvulsant and, was doing fine neurologically, and his
he had to go to work.
anxiety, right, about this was pretty low. He's back to normal, and CT's normal, so.
Would a different mode of imaging have picked up?
Very likely, I think, although it may have been very small at that time. I would think, given what we know now, that it was 7 centimeters 3 months later,
Right.
you probably would have seen something with
I bet the MRI.
Yeah, I bet if you had an MRI, the TT or flare probably would have shown something. But I mean, even if he showed up UAB-ED, this is what would happen. They would make him an appointment in neurology, and then you would, get an MRI or an EEG and kind of work it up from there.
So would a contrast made a difference?
Possibly, yeah. I might have seen something there.
They
It's
tend
done
to
through,
do-
like,
I
bleeds
like to do
primarily.
contrast
That's
with
right.
EEG for some reason.
Is it, what determines how?
But really, in the
you image
ED,
it?
all you care about, do they have a hemorrhage in their brain?
Okay.
For the most part.
That's correct.
And so they'll do a non-contrast head CT like this, and if it's normal, and the person is doing okay, then I would do what they did, set them up to be followed up in clinic and get the workup.
They very often have a CT right in the ER and do this quickly.
Right.
Whereas they can't do an MRI that quickly.
That's right, yes.
Okay, so I think I have the post-op image here. This is post-op, and this we had a trial open for this patient, so it's very important that the imaging be done in the right sequence. So this MRI was done fairly soon after the surgery. So I think I have an audience question here. When should the post-op MRI be done? And nominate for number 1, number 2. It's time for each time. Number 3, within 48 hours.
We've got some, I saw some hands.
Hands
there.
for
We got hands.
radiation. 48 hours for
I thought you said 1 month.
and 1 month
Maybe
after
it's
surgery.
I said that one.
Well, the correct answer is number 3. Although for this study, I think they say 72 hours is okay. But the problem is if you wait too long, you get some scar gliosis, a reaction to the surgery, which will be confused with recurrent disease or persistent disease. So you really want to have a scan done as soon as possible. Some say 48 hours, some say 72 hours. This doesn't always happen in practice, but because the patient was to go on a possible study, we made sure that scan got done. Next one. Okay, so the pathology showed the glioblastoma, and these additional studies are not always done either. This patient actually was being evaluated for a study looking at EGFR inhibition, so the pathology was sent out to a second lab, which had the added benefit of verifying the diagnosis of glioblastoma. In some of the previous glioblastoma studies that were done, or high-grade glioma studies that were done, we find about between a 5% and 10% incidence of the pathology being changed when it's reviewed years later. So it's kind of nice to have a second set of eyes looking at the pathology. I think John and Bert mentioned this morning the importance of the MGMT methylation or hypermethylation. If that's positive, the patients actually do better with alkylating chemotherapy, such as Temodar. This patient didn't have that hypermethylation. And there was a mutation present, a certain mutation that's correlated with overexpression of EGFR. And so the patient actually was a candidate for certain studies that target that mechanism.
So do you send out all your samples for that?
So we have this trial too, and then been screening. So like Roger said, everybody gets a second path review. They get MGMT promoter methylation as a part of that. We're not routinely doing that. If John and I just have a routine patient that's not a study candidate or doesn't want to be involved in a study. But I do think, and then this is just my philosophy, but I would see us moving toward increasingly using that information, particularly as we get more data from RTOG 0525 and 0825, that look at survival in patients unmethylated who are getting Temodar. And if it's not really being improved, then I think we're going to start seeing an impetus to not give it. Now, I think that's going to be a little stressful, one, for patients, but also for, medical oncologists, neuro-oncologists, because we don't have a lot we can give concurrent with radiation therapy.
haven't the trials done so far, haven't they shown a small benefit for those that are not hypermethylated?
Yeah, it's pretty tiny, and the only one that really showed much is Stoop's original. So, I suspect you're dealing with situations where, just like you said, maybe it's, a different pathology or some variant, but the percentage difference is actually quite small. Do you remember?
Low single digits.
Yeah.
I mean, you're way out on the tail of the curve, really.
To
But
kind of
it was
see that.
statistically significantly better. You're right.
What incidence are you seeing of the hypermethylation of GMT?
So, in the studies we participated in, where we screened everybody, it would be about 30% for MGMT promoter methylation. So, the majority of patients do not have it. And so we give a lot of Temodar to people that may not necessarily be all that sensitive to the disease, at a huge expense.
So what is, I'm curious, I mean, because you said that at the University of South Alabama, you screen all tumor sections for the MGMT and the B3, but at UAB.
No, we don't do all of them.
Oh, okay.
We did them because we had a study available.
Okay.
And so to be eligible for that study, you would have to have a gross total resection and also have a good enough performance status. And also, occasionally we don't see the patient early enough to make sure they've got their post-op imaging in timely fashion. So a lot of them that are excluded.
Okay.
But if they're candidates for that study, they would have these things checked.
We're kind of doing the exact same thing. And plus it gives you a chance to get these people screened for this EGR-B3 mutation, which is a newly diagnosed study, there's a recurrent disease study, and there's a bevacizumab failure study. So if you find out, they have a number of opportunities they could participate in clinical research relative to this.
I guess what I'm thinking is, as a basic scientist looking at candidates and questioning, could this actually be a candidate to collaborate with an MD on? I mean, is it overwhelming to think that we keep coming up with novel candidates?
Well, I think one of the things that would be interesting, particularly going back to the lab, or looking at some of the cell lines, either established or the primaries that are MGMT unmethylated, because really that's kind of the group we'd like to begin to have more novel therapies. So it would be, I think, an easier transition to say, look, your MGMT promoter unmethylated, you're less likely to respond to temozolomide. I mean, you have a very low likelihood of responding, but we have clinical trials with investigational agents that show synergy with radiation therapy and, preclinical or animal model tests. I mean, if you told me that, I would say, yeah, I think I'd rather do that. Mm-hmm. Even though there's it's an experimental therapy, there's some unknown risk, but that the likelihood of having a positive from temozolomide is going to be, lowish for you. So that's why I think, when we think about where we want to be scientifically, that's one group. That's 70% of the patients.
I mean, that's just the way you said it was very helpful.
I think our reluctance to say this is standard of care is that we don't do anything different with information right now.
Yeah.
Intellectually, we think it's important. The patient may think prognosis is very important. They may choose to go on a clinical trial if they're unmethylated because their prognosis is good. Or they may make different decisions about their life because they think they're prognosis.
So I'll ask, do you mind if I ask one more question? When I think it was Dr. Partridge, you said there was disparity in the reporting data for the TCGA. And this was Dr. Goldberger, and he said that the older the patient is, the less the data was included in some of the study sets.
Well, I think a lot. And I could have been not understood him correctly either, but I think it's more a lot of the clinical trials where a lot of this data gets collected are often up to age 70 or 75. Now that's kind of gone away a bit for us, but the European study that defined temozolomide with radiation, they didn't accrue anybody over 70 or 75. I think it was 70. So I think he was trying to get more at how you may adjust care for an elderly patient that may have a lower performance status, less physiological reserve, concurrent medical issues. Standard therapy may be quite toxic to them.
It used to be you would not even be considered for a trial if you were
Yeah.
over 60.
60.
Great day. That's young.
So, so now we're post-op. The patient is really a good performance status, no deficits at this point, and seizures controlled. I think he only had one seizure. So the options now are therapy. I've already maybe given away the answer, or he's doing on a clinical study. There were two parts to the study. One was the pathology, which many patients have been evaluated for. We've seen a very low incidence though, of patients with the actual EGFR V3 mutation. I think around 20%. What I've seen published is somewhere around maybe 25 to 30% national positivity for that. So most patients don't get on the therapeutic part of the study, don't have an option. So the options here would be radiation therapy, radiation with concurrent temozolomide. Raise the hands for any of these things. Okay.
That's two we would have to.
I like 2 and 6.
Yeah.
Okay, so I'll move on.
Would you consider, if EGFR was positive, would you consider cetuximab in any of this treatment?
The thought would be that antibody therapy, outside of Avastin, which doesn't really need to get into the brain, would be not that effective, but increasing clinical trials in CNS lymphoma, with other situations seems to indicate that antibodies can get into the central nervous system in some fashion. I really think in those early studies with the EGF, is that a big,
That's a non-specific, no, it's not, it
It's
doesn't
just
bind.
EGF
Yeah,
receptor.
so that's the problem with that particular one.
But I think early studies, didn't they, some of the early phase?
The monotherapy studies were very low single-digit patients that seemed to benefit. It was combined with chemoradiation in Heidelberg. Stephanie Combs did a phase 2 trial. Like a lot of phase 2 trials that are modern, it looks pretty good survival compared to what we did 10 years ago, that type of thing. And it was safe to give. I don't think they've ever done a randomized trial. The group up in Groningen was radio labeling that, hoping they could get it divided to the brain tumors as well. But this vaccine is a very non-toxic, more specific therapy, and I think if there's going to be a molecular therapy for this subgroup, it's going to be that drug. I think that it's an active drug.
So this patient was enrolled in a vaccine trial using a peptide targeting a specific mutation. I'm not sure if it's actually a placebo-blind trial, so I'm not sure if he's getting that agent or not, because concurrent with the adjuvant Temodar, the study does not really specify what you do for radiation therapy. That's sort of the standard of care. And he got roughly 60 beta standard fractionation to the typical margins. It was not my patient, but I think it was more or less RTOG margins, not the real tight ones that John was talking about this morning for the NAVA type margins. And he, so far has done very well in radiotherapy. Still neurologically intact and ambulatory, and no problems. Never had any real side effects with Temodar either concurrently. Occasionally go around into thrombocytopenia with these patients, but this patient had no problems.
This is an important study. It's akin to like Herceptin and breast cancer for patients that are HER2 positive, and it's an incremental step. It's finding this group of people, selecting them out. Now, as Roger said, this study is placebo-controlled and double-blinded, and the placebo is GM-CSF, which is what the vaccine is in also. So if you get a induration or something, that's most likely what's generating that, so you really can't tell. But it's a good study to answer this question, and it's been in 3 or 4 earlier phase studies to include phase 2. And like John said, many of those had tissue markers, and it was depleting the tumor of EGFRB3 positive cells. So it's an active type of compound. It's a good study to be involved in.
Have you guys enrolled any patients on it?
We screened 50 people for this thing, but we only got 5 that were positive. So apparently our area of Alabama, it's a lower. It's about 30% here also that are EGFRB3 positive. So we're trying. We've had a couple not want to do the randomization, so they don't know if they're getting it or not. You're getting standard care, but they don't know, and that's sometimes unsettling for people.
I think we had one that had the mutation, but then refused follow-up MRIs. And so,
Well, good study. It's a good study, though.
this is a case, John, would you present this?
Yeah, so this is a sort of unusual presentation. You may argue this was incidentally discovered. So this is a relatively healthy 32-year-old, and she had some neck pain and a headache after a massage, and the primary care doctor said, was talking to her, she said, well, I haven't been seeing too well either, and just had this sort of incidentally identified on the scan. On the left is a flare abnormality, relatively discrete looking, and it does not enhance after contrast is given. So I guess the question is, for what at least in retrospect may be an incidentally identified abnormality, because I'm not sure headaches are really related to this, what would we do? I guess maybe we would start with Tony or the group.
If, the incidental finding like this, is in the right, you could opt for a couple things. One is to just observe this and follow this closely and see if there's any changes. And just, repeat the scan in a few months. Would be one option for it. The other option obviously would be to get a biopsy and then find out what the path is and determine whether, further resection would be an option.
How do you decide between a biopsy and proceeding with a resection at this location?
Well, I think this is close. Looks like it's close to the motor cortex on that side.
So biopsy first.
I'd probably biopsy first. So
You get a lot of patients who've had brain imaging for whatever reason that have incidental findings. Now this one is a little more concerning, but a lot, will have very small little flare abnormalities that it's unsure the significance. Some of those will turn into glioma. When people don't have a good neurological reason for presentation, I tend to follow, but this one's a little big for me. I think I have
The
to
sizes.
yeah. There are different surgical options you have as far as, mapping that area of cortex and trying to minimize any morbidity from the operation.
I guess people in the back probably can't see, but this one on the right is the post-contrast scan. So there's more aspect also. What would you think that most likely was, given that presentation?
Well,
Given that age?
I think we were thinking it was a low-grade glioma, but then some of these can be, higher grade, and you can still not enhance.
A few more
Which I know what it
slides.
is too. So. All right, I think there's another slide here. So this person ended up having a resection, and on the left is the contrasted scan. So they're flipped here. This is post-op day 1, and thought to be a gross complete resection at the time of surgery, but there's a little bit of residual flare you can kind of see posteriorly immediately. That's a little bit thicker there. We weren't sure if that was any residual or not. And the path was a diffuse astrocytoma WHO grade 2. So this has been almost completely removed, perhaps.
Tony, any surgical comments?
That's a pretty clean resection site. There's maybe a little bit posteriorly. Looks like that posterior portion, but did they do this? They did it stereotactically. Did they do?
I'd have to go back and double check
what
some
they
of the
did.
details exactly. Yeah.
Yeah.
So Bert, what do you think we would do in tumor board with, especially she did have 2 post-op seizures and had to be started on medical management for that.
Did you do any kind of extra studies on the pathology?
I don't think we did for this one. You know, some of the more common things you'd see would be IDH1 mutations for low-grade gliomas. About 80% of these were done. There's an immunohistochemical stain that can identify the most common R132, I think that's what that's called. And those patients do a little bit better. And then you could look for other like motors and 1p19q translocations as well. So not on this at this time. So she actually we didn't think she needed any adjuvant therapy, and national trial for these people is looking at the quality of life, cognition, and seizure frequency after resection. She was categorized as low risk by the RTOG EORTC criteria. There are 5 variables in that schema, and they include whether you have any oligodendroglial histology, your age, the size of your tumor, whether it's bilateral, and the extent of resection. That's fine. And so she was enrolled in this trial and did well in terms of radiographically for a couple years without any progression. But her seizures increased in frequency over that time period. Additional medications were added, and we were left with a stable exam, MR exam, but a worsening patient in terms of her seizures. So, Bert, at what point do you think about whether we need to do some other therapy?
So I think what our kind of practice is, we'll one, monitor MRI, and one comment I would make about this is, Roger, go back one slide to that post-op. When the radiology is not going to do this, they're going to compare it to the last scan, but you have to go back to this, because that flare is going. If you've elected not to treat with radiation and you're going to monitor, that flare is, it's untreated disease that's infiltrated into that margin. It's going to change, and it may be very slowly, but if you only compare it to the last MRI 3 or 6 months ago, 5 years from now, you're going to look back to this and go, oh my God, this thing is a whole lot bigger. So it's really critical to make sure you go back and compare it to this baseline. So radiographic changes would be one concern for recommending treatment. Now, I think you've got to take it into context. If they're very subtle changes, they're gradual over a long period of time, and a patient doing well neurologically, I'll educate the patient to that. I may continue to monitor that and not necessarily elect to treat. The second parameter that we use is neurological function. And I'll let John comment on it, but I'm remembering who this is. I think I've been through 3 anticonvulsants in this young lady. This is clearly the factor that's impacting her quality of life. Otherwise, somebody who would be functioning at a high level, but having persistent seizures. And so electing to move forward with treating the underlying cause of the tumor, or the seizure, the tumor, with radiation therapy may initially cause a little bit of an increase in seizure frequency, but ultimately, usually these people get substantially better seizure control, at least I think in our experience.
Yeah, so one of the indications we have for radiation is medically difficult to manage seizures, particularly if the seizure medicine is causing trouble. The group in France, in France, looked at about 100 patients with grade 2 and grade 3 tumors at ASCO a couple of years ago. They had 50% reduction in seizure frequency at 1 month follow-up after radiation, and 70% at 3 months. So I was rather impressed that it was that frequent. And when you talk to some patients, in fact, that is what you see even during the therapy. They're having a reduction. We will go to the next slide here to sort of finish the story. Yeah, so we had planned to enroll her in the follow-up study, which is actually a treatment, say for RTOG and ECOG, so it replicates the Stoop regimen, which is radiation for this patient versus chemoradiation. And she actually had the consent form, and we got this press release from NCI actually in February that they were stopping that trial because of the findings from RTOG 9802. And that was a study that was started in the late 90s for patients with low-grade gliomas that were high risk by different criteria. They're randomized to radiation or radiation plus PCB. And I think there's a few curves here. So here's that study schema. And the low-risk patients by this schema were observed, and then high risk if you were over 40 or you had a subtotal resection. Now we use a little bit different criteria now. But this was the schema that they had. And you were randomized to radiation alone or radiation plus PCB given after the radiation for 6 cycles. And this is the last publication, which was in the Journal of Clinical Oncology in 2012. And I think Ed Shaw was the first author on this. But the PCB patients were doing quite a bit better in terms of progression-free survival. But when overall survival was evaluated, go to the next, this was a trend, but not statistically significantly better. So the interpretation was you could get your chemotherapy now or later, and you would live the same amount of time. And the press release was that this actually now has a survival advantage. And what we don't know is the molecular subtypes of these patients, and it's going to be 6 more months before we know that. So they stopped the chemoradiation versus radiation clinical trial with temozolomide because of these findings.
And that's it. To me, I'm a little disappointed in that, because at the same time all this came out, the UCSF group published in Science a paper where they looked at patients with low-grade glioma, astrocytoma, treated with temozolomide who rapidly progressed to grade 3 or 4. When they dissected out the mutational fingerprint of that progression, it was temozolomide induced. It wasn't a cancer oncogene that caused it to occur. So, and it's a small number, but it's pretty powerful work. So this study, they're using PCB. Okay, so again, an alkylating agent, 2 other drugs, combination that we used to use a lot, but to be honest, I haven't, I could give it, but I haven't given it in a number of years. It is relatively toxic, and most patients can only tolerate about half the treatment course of it. And the importance of that RTOV study that got stopped is it was adding Temodar. At least we could answer the question within the context of a clinical trial. And I'm a little hesitant now with the low-grade glioma, unless they carry high-risk features, of adding temozolomide to their radiation, because they're typically people that will do well. Particularly somebody like this, who's had a nice resection, minimal residual disease, high functional status, young age. So I'm on the NCCN Guidelines Committee. This got brought up, and I tabled it to next year because I felt like we just had to get a little more information about it before altering the guidelines, relative to this. So, a very interesting, little area that we're in.
I was noticing, the follow-up MRI scans, we have different, it was every 6 months on this. Do you have any differences between this and, say, a higher grade glioma?
So, NCCN guidelines, we kind of give a range, and we say 3 to 6. And outside of medulloblastoma, really in children, I don't know that we've ever had any kind of study that looked at an appropriate frequency. Some clinical trials have been up to every 6 weeks when people are under treatment. I think 2 to 3 is very reasonable for people under treatment, and if you're under surveillance, every 3 to 6 is fine. But I also think as we get some of these molecular markers like IDH1 mutation, moving that window out would be, an economically appropriate thing that shouldn't jeopardize patient safety if we can define these a little more specifically. So if you got an IDH1 mutation, you could go every 4, probably pretty safely, versus if you do not, maybe you need every 2. So it's just an example.
Did this patient get treated with radiotherapy twice?
So she's finishing her radiation this week, and we have not added any chemotherapy. We talked to her about, this was the study, she was willing to go on this first study, but given that she has a diffuse astrocytoma without any oligodendroglial features, perhaps we could argue she's less likely to benefit from chemotherapy. So I don't think she's going to have the chemotherapy unless we really stand up and shout. Now, some people would probably disagree with that.
What about the cases where we don't have a tissue like brainstem glioma, where usually they're grade 3, but occasionally you think it might really be grade 2 based on imaging? Would you lean toward giving concurrent Temodar in those cases?
I think we generally have. Wouldn't you agree?
Yeah, the children have gotten Temodar and Avastin up until now. And some of them have done very, very well in terms of time to progression. I don't know that they're living that much longer. They just still be dead.
And
So
most
I
of
benefit from that.
the adults we've treated with brainstem glioma, non-enhancing, just the infiltrative expansile ponds, obviously I think they do better than children with pontine gliomas. And then if they've got a more midbrain or medullary exophytic type thing, then they often do actually pretty well. They'll do pretty good. We have been giving them Temodar.
What was your dose for this?
50.4.
Is that just standard for you pretty much? Or I think Shaw recommended 54, and some say you can stop at 45.
So we have studies looking at different doses, and I guess the lowest dose is 45, and the highest dose is 64.8 that's been tested. There is a dose response for toxicity beyond 50.4. So that's what we do.
I asked Shaw that question once because there were 2 trials. One was 50 versus 65, I think, and then 45 versus 60. And so I was arguing that you really could justify 45. And he said, well, it's true, but he gave 54 anyway.
Yeah. But her seizures have gone away in treatment too. So we haven't changed her seizure medicine yet.
So hopefully
The
we'll
best-
scale back.
Yeah.
Was there any sign of recurrence on MRI before you started radiation?
The flare thing might have been a little bit thicker, but we had the rating all the way through. Is that correct?
Yeah.
But no enhancement. It wasn't enough. If she wasn't having any new symptoms, we wouldn't have treated her.
Well, it never enhanced to begin with, but so the recurrence might have been still a low grade, not enhanced.
That's our theory.
That's kind of what we're
But,
treating her as.
it's not infrequent that we have these grade 2s, seizure frequency increases, you put them on seizure meds, they get a little better, and then the next scan shows enhancement and transformation.
And that's your
That's
first
the
case of the
hallmark.
GBM,
Yeah.
seizures. So seizures, obviously it's a tumor-associated or provoked, event.
That might be the last slide in this case.
How far from the initial surgery did she have the symptoms again? The time interval?
Before that,
Surgery to seizures.
within a week, it was 2 in the first week.
But from the time of the surgery till we elected to treat her, it was a year and a half.
I was thinking it was between a year and a half and 2 years.
Yeah, it was I flailed away with anticonvulsants for a while.
Okay.
So, it was, we were kind of, and she was beginning to get into that state of a little bit of mental health and emotional because, the seizures are unpredictable, they're interfering with work, she can't drive, kind of independent professional. We were getting to that point we needed to do something to really gain control of the seizures.
This was the study that they stopped, that she was going to.
Did they accrue a number of patients on this one already? So
They have, we put just a handful on, but not sure exactly where they are overall. But there'll be some analysis performed, for sure.
But they stopped it because they thought there was no benefit, or there wasn't enough.
They stopped it because there's a radiation alone control arm, and
Oh, they were worried about
they
that.
just had a trial that showed that PCB had a survival advantage. So
So now that's interesting.
I'll
But-
study
but I'm
the
still
people stopping the
arguing.
trial would say you gotta give everybody PCB. You know, you gotta treat them.
Arguing against that.
So- I think this was another similar case. What's the right workup here? So this was a 71-year-old who, he's pretty high functioning, and he said he couldn't understand written material, and went to his doctor, and maybe was having some headaches, but not anything else. And they ended up doing these scans. And we have a
So flare on the
single flare abnormality on the right, but multiple enhancing lesions there on the left. On the left scan.
Might be the last slide.
I think that's not.
Let's go back to that. Tony, what are your thoughts being on the left?
That one, I do a needle biopsy on, there's no doubt.
And how would you decide what to biopsy there?
The biggest one.
The
That'd be
biggest
the
one,
easiest,
okay.
that'd be the easiest one to approach. I mean, it's just a better target. You're gonna get a better sample for the pathologist.
Yeah.
You know, I think that's really probably the best option.
Yeah, so he had a metastatic workup before that, and they didn't find anything either. And this was a glioblastoma as well. So sort of multifocal little enhancements. So Roger, this is an example, I guess, where if you just contour the enhancing abnormality as your GTD, you might be missing some of the tumor there. So this is a potential outlier from what the rules would be and what should be treated with radiation.
There's alternate imaging modalities,
Yeah.
this kind of thing.
Yeah.
Now, do you have those things available at UAB right now?
So we have a new fancy cyclotron they've just put in, so I'm hoping that we can do some carbon 11 on that. We haven't yet.
Low-grade glioma patients that were sent down, and they do something called a relative
Or the ADC maps? Or?
relative blood.
The perfusion.
That's perfusion.
RCDV.
Yeah, you're right. There's a study from England, I think, where they look at using that type of perfusion scan to predict transformation from low grade to high grade, and it's pretty significant. The thing they did in that case to rule out that kind of progression was a negative scan. Do you use that quite a bit up there, David?
Well, they will routinely do it. All it involves is, and I can say all, but obviously it's the technicians in MRI, it's time contrast administration, so a power injector has to give the contrast, and you have to track the bolus through the brain on the first pass, so a very fast T2 star sequence, and you get, blood volume on the first pass, how fast it went through, so you get flow. And they do it routinely on all the brain tumor patients, and we try to use that information for, just like you stated, is this treatment effect versus disease progression, or is it a low grade that may have an area that's showing transformation, that if we ask the surgeons to go in and biopsy, we could say, we want to get a piece from this spot. It's still something we're trying to find how best to utilize. So it doesn't require anything different for the patient when they get their MRI. It's no more contrast, no more time. It's just a power injector injects it. It requires a little more work on the radiologist side to do the perfusion interpretation. And I will say we've had times where it showed elevated perfusion. We got the surgeons to go in, biopsy, and all we could get back was radiation necrosis or treatment effect. So it's not perfect, but I think it's a piece.
Let me ask you, there's a recent case that I've seen that had almost a similar presentation on the right with those flare changes, except there was no enhancement at all. And the problem, that we run into with biopsies in those is that the yield, what the biopsy, and the yield on those is notoriously low.
Yeah.
Although they were started on steroids for the edema, they did improve, and we're just following it this time. Would you
Yeah,
do
that's,
anything different?
well, I think our neurosurgeons are very similar. When we have flare-only stuff that, in the mass, there's not much, see, there's a little mass effect with that.
Right.
But a lot of times you'll have this more wispy flare stuff and neurological changes, and it could be inflammation, encephalitis. And we often ask the surgeons to biopsy a lot of that kind of stuff. And unfortunately, like you said, the yield is low. I think it's got, more of a nodular area in it. I think we would push them in that direction.
Yeah, this one, no doubt.
Yeah, well, we have a similar thing.
It was biopsy, I assume.
This was biopsied and it's a GBM.
All right, I'm going to abandon you.
Okay.
I've got a 13-year-old has her birthday party tonight. I got to get to Birmingham, or my wife is going to kill me. I enjoyed it. It was great.
This is a case I alluded to earlier, and I guess I would just maybe walk you through what we did. And so this was a GBM that was resected here. He got post-operative treatment, and then he developed a series of distant recurrences and was placed on bevacizumab. And each time it failed, it was in a new spot, and he never had progression of where he received radiation. And every time we thought, is this the wrong thing to do because he's got a new spot? And very often, we were able to re-irradiate him safely, and he just stayed on the bevacizumab. So it was from a toxicity standpoint, and from the patient's perspective, it was a well-tolerated therapy over a 3-year time period. This is not absolutely typical. Very often, it's more diffuse problem. But it almost was like a metastasis patient where you gave focal therapy and you had new spots showing up.
The first imaging wasn't that typical of the GBM, though. So were these recurrences more typical, or were they the same kind of wispy?
Well, you had these types of things appearing on flare. Was the predominance of what we were having to deal with. And you can see on that bottom one, which is the last treatment, we had a lot of changes both related to treatment and his previous tumor. They weren't changing. And deciding what really needed to be treated was difficult.
You did biopsy.
Surgeries?
Yeah, one surgery originally and one in the upper right-hand corner. We retreated an area anterior completely.
You keep a composite of all the.
That's what that was, and trying to be sure that we didn't, hurt anything that was really important.
What was the overall survival?
He lived almost 4 years total. So, but his quality of life until the very end, I think, was pretty good. And I guess, along the way, you could really question, are you going to re-irradiate this guy again? But in retrospect, for this individual, it was a good choice and safe for him.
Well, this is a case of a 46-year-old female who, at the time of this scan, was, I think, 38. And presented with headaches and was found after some time to have this finding on MRI. And so the question is what to do here to make a diagnosis. So Tony, you saw this out. How would you interpret that? Anything it would be?
It looks like a meningioma, or that's at the skull base, and it's encasing the carotid, so I think, you could biopsy this, probably do an open biopsy, that's what I would have liked to do, and take out a little bit, but you're not going to be able to resect this without a significant morbidity.
So you wouldn't do a transdermal for this?
Well, I'd have to look at the other images. I mean, you could get a some way to get, you're just going to get a biopsy that way.
I think it was done open.
Yeah.
And it was, as you predicted, a Group grade 1 meningioma. The patient had some neurological deficits after the biopsy, 3rd, 5th, and 6th, like lone pupil and diplopia.
Would you have offered treatment without the biopsy?
I think it would be It's best to get a biopsy if you can.
I understand.
But some where it's risky.
There'll be problems though too, yeah.
And there's a risk of treatment as well, so you could consider, if you had fairly frequent follow-up scans, and there's not much change, you might follow for a while. We were like,
Well, is it gonna change how you would treat this if it was a higher grade meningioma?
well, you use radiation, but
Well, yeah,
the
but would it change the kind of radiation that you're gonna do? So I guess you could wait
well,
for,
if you had, say, this is not really a candidate for radial surgery, this person with chiasm,
Right.
I'd say, so you would consider that kind of treatment for a low-grade one, but not for a high-grade meningioma. And you also have larger margins for a malignant meningioma or atypical. Whereas with the smaller, this kind of low-grade one, you usually have like 3 to 5 millimeter margins if you put fraction rate. Radiotherapy.
so how would you treat it then if you did not have a biopsy?
So we treat some people without biopsies, and we have, you have to remember, in individual cases where everybody went, wow, I'm really glad we biopsied that one. And for whatever reason, you think back, well, why do we biopsy this one versus the other 100 and something that we haven't biopsied? Our unbiopsied meningiomas, we have an 8-year, 95% control rate with radiation-based modalities. So from a knowing when it's a grade 2 or not, we're looking for edema and size, usually. The skull-based tumor in a 38-year-old, we probably would have biopsied this one actually at 38, but I bet if she was 68, we wouldn't have. If she had her ipsilateral, 5th or 3rd nerve palsy, and that was there over months, we probably just would have radiated her.
So, some recommendations here. The patient was just followed, so there was no further surgery. I think it's not really possible to resect that degree. No radiotherapy was offered at that time, and she was followed, and she did well. It was low-grade meningioma. I think it's reasonable to follow that. Although, given the location to the chiasm, you want to follow closely. Any progression, there could be some significant deficits. Then she developed some new symptoms. This is the original MRI here. It hasn't changed yet. With nausea and a seizure. This happened 8 years later. And there was some progression by this point. So she wasn't followed that closely after a while to allow this to progress. And there was on the corona cut, also some progression there. But no visual deficits at this time, just the nausea and seizure. So at this point, what to do next?
I'd be calling a neuro-ophthalmologist to say, are you sure? It's,
Well, I don't think I saw her at this time, but she did. I saw her shortly after this, but she did see one, but not before something else happened.
okay.
But she had no real documented deficit in visual fields at that time. Let's see what we got here. So there were also some edema. If you look at the flare up here and the T2, you see edema lateral to the tumor and temporal lobe, and that's usually a sign of a malignant transformation of or it can be a sign of that.
She's still having the same problems from the biopsy the first time.
She did. I think the diplopia reversed with time, but she's always had the facial paresthesia and the lobe pupil since that time. So given the progression here, she was referred then for surgery. Let's get a biopsy. I think she was referred for surgery, but was not really a candidate for it. She went to Harvard, and well, I'll skip this one. She was seen at Harvard when I attempted developing surgery, or really I think just a biopsy. They only took out about 1 cc of that mass in the specimen. And this is the post-op imaging after that right frontal craniotomy. And the pathology was a grade 3 rhabdoid meningioma. With, this is not actually her slide. I couldn't get a copy of her slide, but that's a typical appearance of this rhabdoid meningioma, which is one of the higher grade variants. that and I think anaplastic variants are the most common. So these are very, very aggressive, can be fast growing, can threaten the patient's life. So in this kind of situation, she needed some kind of therapy, and so she was referred back for radiation treatment. So at this point, the options are, the raise of hands, more surgery. Don't need chemotherapy. We don't have birth history, we don't know. Radiosurgery, probably by itself not a good option because the proximity of the optic apparatus. Radiotherapy, yes, and hospitals probably not yet. Hopefully not for a while. So what we did was the difficulty here is that the optic apparatus is so close to the tumor, and but you can still see it very clearly. So you can see the optic eyes and very well, optic nerves very well. So there's no doubt about where they were. You weren't worried about a case where the tumor had encased the optic apparatus and you couldn't see it anymore. And that's always a concern because a malignant tumor, you really you can't see the eyes, and you have to make sure you can spare it in some way. So we gave her fractionated radiotherapy, and then used the CyberKnife to boost the portions of it away from the optic apparatus. So the optic apparatus sees a dose of a safe dose of 50 gray in standard fractionation, but we boosted the inferior portions of it as high as we could. I think that's kind of a debatable approach in a patient with a malignant tumor. It's the kind of thing we use very often for a benign tumor, where there can be some benefit to treating part of a benign tumor if growth of that tumor is going to cause some compression of the optic apparatus. Whether it helps to do this kind of thing in a malignant case, I think is more debatable, but at least it's safe and you get a little bit higher dose than you could otherwise achieve. So that goes about as high as 70 gray. I think I tried to get about 5 gray per fraction to the inferior portions of the tumor, but could not quite do that and still respect the optic apparatus. So usually we get about between 4 and 5 gray per fraction to those lower portions. She's done fairly well, though. So this is the initial post-op scan. And then look at the follow-up scan 3 years later. There's been some regression and no growth. We did have fairly substantial margins on the fractionated part of that. The CyberKnife margins were tight, but the fractionated part had about a centimeter margin dosimetrically around this disease. And the edema also was covered. The edema in the temporal lobe after surgery was covered also on the left side, on the right side. And she's followed with ophthalmology, and there's been no visual deficit. Still has a blown pupil, still has facial paresthesia on that side of her face. And she also has, all these patients tend to get high dose of radiation to the pituitary, and usually they just wind up on Synthroid and cortisol. That tends to be a late reaction. So that's the other one. So no complaints of anything wrong.
Yeah. What did you accept as the risk to her vision relative to your desire to give a high dose to tumor that was right next to it?
Well,
How did you balance those two?
That's a good point. I didn't want to go over. Yeah, you could consider going higher for livable, and I think in some of the GBM trials, for example, GBM studies, you typically go to 60 gray. Or you could justify that. And trials have been done that way through RTG, given that kind of dose. Because you know the likelihood of them dying or losing their vision due to tumor progression far outweighs what you would achieve with the tumor or with radiation. So in this case, it was more of a judgment of
You accepted a few percent risk of causing
I think I accepted, in this case I really accepted almost no risk.
Uh-huh.
I kept it at 50 gray, and there really have been almost no documented events of visual field loss at 50 gray standard
Yeah,
fractionation.
you're very there.
So if you go above that, like 54, you might have some kind of 2 to 5% risk of it. There have been a few cases reported like that. So I could have gone a little bit higher to the optic apparatus. And I actually did go a little bit higher. My point dose is higher than when I showed these curves. So I had a little bit higher threshold because of the malignant. But I didn't treat the entire thing deliberately to a higher dose. I don't think that would
The
be wrong.
Quantec data suggests that you can push to 54, probably at 2% or less risk. 55 to 60, it's about 7%. Then it asymptotically rises.
Yeah, I've caused 3 neuropathies that I know of in 16 years. And the lowest dose that I caused was 50/24. I don't know why that person had it.
That's
The other
unusual.
one was about 55.
Was that the, we had that old fashioned pre-chemotherapy.
One of them was on the Peacock, you're right. It was the Nomo's Peacock system. That patient had a prescription that was just over 55 and just over 100%, so about 57. 2 others.
Yeah, I guess part of my thinking here was that I knew where the edema was around this tumor also. And it really wasn't around the eyes. So I was thinking this was a benign tumor that had progressed. They don't believe in areas.
This is a very difficult situation because there's not another therapy that's going to be active. You don't.
And
Don't
then
take care
also-
of it with radiation, then it's unlikely surgery or any other systemic therapy is going to be helpful.
I think it's also uncertain to me that getting 54 Gray instead of 50 would make a big difference in control of it. So take a bit more risk, but you really gain any benefit by getting a few more fractions by a higher dose.
Yeah. I don't know the answer. I just
That's one complication I've been able to see. It turned out well for her, but may have gotten lucky. You know. So this is an interesting case that actually was up at UAB also. 58-year-old female, and she presented with gradual vision loss over about a 6-month time, and she also had some increased tearing and nasal secretions. For reasons I can't recall right now, she had an MRI 3 years prior, and on that scan there was nothing there. Although she had, I think she had a small cystic area next to one of her ventricles, which was an incidental bloma, not significant. So she presented with this this mass involving the cavernous sinus on the left, and it looked down. I don't know all the cuts here for this scan, but there wasn't really much edema around. I don't think any edema really. They extended down to the pterygopalatine ganglion behind the maxillary sinus, and that's why the reason she had this lacrimation and nasal secretions. She was seen by, I think, a neurosurgeon in town and then sent to UAB, where you may have seen her, John, I'm not sure. And she was seen by the neurosurgeons at that time as well. Well, it was thought to be a meningioma, and they did not recommend regular surgery because of the proximity to the optic nerve. I'm not sure if I showed these images here for the optic nerve. Wait. This shows how close it is to the optic nerve. There's tumors that are wrapped around the optic nerve. So they didn't want to do a biopsy either. Thought it was a meningioma, and as you said, John, they were thinking seriously about not doing any kind of biopsy here, just recommended radiation therapy. And so she came back home, and I saw her because she lives in. At that time, this was probably, I think she had started losing her vision around the summertime. I think I saw her probably around October. And at that time, she really had no vision in that eye, apart from seeing shadows. So she'd gone many months with really no usable vision. So I think there was really no hope of saving any vision on that side. But so I talked to my colleagues about getting some tissue to see what that really was, because it was nothing.
And as you get ready to show this, I was thinking at the beginning of the slide, well, this is one we clearly would have biopsied.
Oh, really?
Obviously, we're not.
I wish you had said that. Oh, no, you did. Okay.
Yeah.
So I we got it biopsied by ENT, and it was first read out as a small round blue cell tumor, and which in that location you might think it could be an anesthesia neuroblastoma or perhaps something like a PNET or a rhabdo. But then it was read by Sharon Weiss at Emory. She's probably the world expert on sarcomas and soft tissue tumors. And she thought that was a meningiocarcinoma, which is a similar tumor to a meningioma, but tends to be more aggressive, and also has some metastatic potential, like 15 to 25% risk of distant metastases. So in this case, it didn't really, well, it did affect your therapy, but this took a few weeks though to get this done, which, took maybe 2 weeks to get this done. The time to just talk to people about biopsy, getting biopsy, and getting the review back from memory. So there was some delay. No real change in the vision over that time. But if I thought there was some chance of preserving the vision, I might have acted sooner. So we did the same technique. This one actually, I didn't intend for this, but in two of these cases, we used the same technique of fractional radiotherapy with the margin around a malignant tumor and boosting a portion of the tumor away from the optic apparatus. In this case, it was possible because you could still see the optic apparatus very clearly. For the typical kind of case of pituitary macroadenoma, you know it's a benign tumor pushing the chiasm up. So you can't see the chiasm, you know where it has to be. In this kind of case, the tumor can infiltrate around the optic apparatus. So you really want to make sure you see it before you try something like this. So in this case, we did the same kind of scheme, same dose, we hit the optic apparatus to 50.4, pushed the inferior portions as high as we could go, and we actually did this planning with Monte Carlo technique. So one of the nice things about the CyberKnife system is it has Monte Carlo dosimetry built into it. And it doesn't really make much difference in most brain tumor cases because you're far from any air. But when you are near air, like maybe some maxillary sinuses, they can affect your dosimetry in here. The colored areas show the uncertainty of the dosimetry calculations, which goes up if you're in the air. And it did actually affect the doses that we gave to the optic apparatus slightly. So it does pay to do a more quantitative check with Monte Carlo for this kind of case when you have the area of the target. Didn't change the dosimetry of the treatment very much. And we did have to represcribe a different dose slightly because of the Monte Carlo calculations. So I think here it shows the coverage is about the same. It's red arrows in the bottom, 95% coverage roughly with Monte Carlo, and slightly lower. But the optic apparatus was slightly higher. Left optic nerve, 12.5 gray instead of 11.5. So the truth was a little bit worse than what was intended. I actually, this patient actually had a responsive therapy, so I had to replan the CyberKnife because the tumor shrank a little bit. So this one did not actually get treated. It was a replan. And that shows the optic apparatus goes slightly worse. And amazingly, the patient's vision started to get better. Tumor shrank with the first few treatments. And so I had to re-image her and replan her with another MRI. And she now has normal vision again. It's amazing. But, she had a complete restoration of her vision. And no metastases at this point, so that's going to be a long-term risk. Typically, these patients get mets 6 to 10 years out, that kind of time frame. But the incidence is about maybe 20%.
How often are you doing surveillance scans?
I would say maybe 6 months. I think you'll need to do it that frequently. She had a negative scan workup before we started.
Some of the patients that have metastatic disease can even be very indolent. So,
Yeah.
Had 2 sites of metastatic disease. We aggressively locally treated one with spinal radiosurgery, and the other was a resected scapula. And she's NED now another 3 years. So it isn't like a lot of diseases where you get metastasis and they blossom and keep on going. Sort of an oligometastatic picture.
Do you treat those if you have met somewhere?
We
radiate?
we treated 2 of our 3 metastatic sites with radiation, 1 with primary surgery.
This is the response on the MRI. This is the MRI that happened about, I think it's months after, 3 months after. When they say this, so it's pre-treatment, and so 4 months after. So it sort of does change the appearance of the sphenoid sinus. There you get that sort of reaction. fraction side, all that area is covered with the fractional radiotherapy. The cybernetic portion was a very good portion of that region. I did cover the lateral wall of it because that's where the biopsy was done, so there it was contaminated, extended up here to the foot of it. Part of the cybernetic plan, part of the entire, some of it was covered in the layer. We're on to,
That's it.
I think that was fast. Let's see how we go for time.
We're done.
Okay.